inflammatory response syndrome, and multiple organ dysfunction syndrome, SIRS and MODS. SIRS is a systemic inflammatory response to a variety of insults. It's a generalized inflammation of organs far from the initial insult. Some of the triggers include mechanical tissue trauma like burns, crush injuries or surgical procedures, abscess formation, and ischemic or necrotic tissue. Microbial invasion can cause SIRS, endotoxin release from gram-negative bacteria, global perfusion deficits, and regional perfusion deficits. MODS is the failure of two or more organ systems. Homeostasis cannot be maintained without intervention, and MODS results from SIRS. These two syndromes represent the ends of a continuum. The transition from SIRS to MODS does not occur in a clear-cut manner. This is a schematic of the relationship of shock, SIRS, and MODS. And you can see that people progress from any of the various types of shock to systemic inflammatory response syndrome, and then to multiple organ dysfunction syndrome. KR is a 28-year-old woman who was brought to the emergency department by her mother with confusion, fever, and flu for the past week. She's been vomiting for the past couple of days and has noted generalized edema. Her vital signs are temp of 103.5, pulse 112, respirations 24, and blood pressure 88/54. What is this patient at risk for based on her vital signs? And why does she have edema? Well, she's at risk for decreased perfusion and coagulation or microemboli. And she's got edema because of increased vascular permeability. There's an increase in the vascular permeability that allows mediators and proteins to leak out of the endothelium and into the interstitial space. White blood cells begin to digest the foreign debris, and the coagulation cascade is activated. Organ and metabolic dysfunction occur with hypotension, decreased perfusion, formation of microemboli, and redistribution or shunting of the blood. The respiratory system is often the first system to show signs of dysfunction in SIRS and MODS. Inflammatory mediators have a direct effect on the pulmonary vasculature. The endothelial damage from the release of inflammatory mediators causes increased capillary permeability. This causes movement of fluid from the pulmonary vasculature into the pulmonary interstitial spaces to the alveoli, causing alveolar edema. Type 2 pneumocytes are damaged and surfactant production is decreased, causing the alveoli to collapse. Alveolar collapse creates an increase in shunt and worsening of the ventilation-perfusion mismatch. So the increase in shunt means the blood flow to the lungs doesn't participate completely in gas exchange. The end result is ARDS. Patients with ARDS require aggressive pulmonary management with mechanical ventilation. The baroreceptor reflex causes release of inotropic and chronotropic factors that enhance cardiac output. In other words, the baroreceptor reflex causes a release of factors that increase the force of contraction and the heart rate, so the cardiac output is enhanced. To compensate for hypotension, cardiac output increases with an increase in heart rate and stroke volume. Increases in capillary permeability cause a shift of albumin and fluid out of the vascular space, further reducing venous return and thus preload. Other signs include decreased capillary refill, skin mottling, increased CVP and pulmonary artery wedge pressure, and dysrhythmias. Mental status changes are due to hypoxemia, inflammatory mediators, or impaired perfusion, and the patient may become confused and agitated or combative, disoriented, lethargic, or comatose, and these are often early signs of MODS. Decreased perfusion to the kidney activates the sympathetic nervous system and the renin-angiotensin system. The stimulation of the renin-angiotensin system results in systemic vasoconstriction and aldosterone-mediated sodium and water reabsorption. Careful monitoring of drug levels is essential to avoid the nephrotoxic effects. In the early stages of SIRS and MODS, blood is shunted away from the GI mucosa, making it highly vulnerable to ischemic injury. Glycogen stores are rapidly converted to glucose, called glycogenolysis. Once glycogen is depleted, amino acids are converted to glucose, which is called gluconeogenesis, reducing protein stores. Fatty acids are mobilized for fuel. Catecholamines and glucocorticoids are released, resulting in hyperglycemia and insulin resistance. The net result is a catabolic state, and lean body mass or muscle is lost. The liver cannot make albumin, one of the key proteins that has an essential role in maintaining plasma oncotic pressure. Consequently, plasma oncotic pressure is altered and fluid and protein leak from the vascular spaces to the interstitial space. Administration of albumin does not normalize oncotic pressure in these patients at this point. As the state of hypermetabolism persists, the patient cannot convert lactate to glucose, and lactate accumulates, causing lactic acidosis. DIC results in simultaneous microvascular clotting and bleeding caused by depletion of clotting factors and platelets combined with excessive fibrinolysis. Electrolyte imbalances are common and result from the hormonal and metabolic changes and fluid shifts. These changes exacerbate mental status changes, neuromuscular dysfunction, and dysrhythmias. Metabolic acidosis results from impaired tissue perfusion, hypoxia, and a shift to anaerobic metabolism with a resultant increase in lactate levels. So KR is admitted to ICU with a possible diagnosis of sepsis. Her urine output is amber and only 15 milliliters for 2 hours. Chest x-ray shows bilateral infiltrates, and her white count and lactic acid levels are elevated. What are the assessment priorities for her, and what are the appropriate nursing diagnoses and goals? One of your goals is to prevent the progression of SIRS to MODS, because this patient is exhibiting symptoms of SIRS. So you want to do vigilant assessment and ongoing monitoring to detect early signs of deterioration or organ dysfunction. The MODS mortality rates are 70 to 80% when 3 or more organ systems fail. Survival improves with early goal-directed therapy, and an example of a sepsis alert protocol is available on the Evolve website for this chapter. Other collaborative care for patients with MODS focuses on prevention and treatment of infection, maintenance of tissue oxygenation, nutritional and metabolic support, and appropriate support of individual failing organs. If you see Table 6711, it summarizes the management for patients with MODS. KR has a urinary catheter inserted as well as a central venous catheter. The doctor talks with the mother about the possibility of mechanical ventilation, and the mother wonders why she's so sick and what can be done for her. So what other interventions would you anticipate, and what are the rationales for the interventions that the doctor has discussed? And how would you respond to the mother? Well, the urinary catheter and central venous catheter is to measure intake and output and fluid pressures and levels. because you're going to monitor carefully for renal failure. Mechanical ventilation would help KR rest. Antibiotic therapy would take care of any sepsis, and sedation and nutrition might also be other interventions that you would need to talk about or anticipate. So, as for the prevention and treatment of infection, early aggressive surgery is needed to remove necrotic tissue from burns that can provide a culture medium for organisms. And aggressive pulmonary management, including early ambulation, can reduce the risk of infection. And strict asepsis can decrease infections related to intra-arterial lines, endotubes, urinary catheters, IV lines, and other invasive devices or procedures. As for maintenance of tissue oxygenation, these patients have greater oxygen needs and decreased oxygen supply to the tissues. So oxygen delivery can be optimized by maintaining normal levels of hemoglobin, so you may be transfusing some packed red cells, and maintaining the PaO2 between 80 and 100, using individualized tidal volumes with PEEP, positive end expiratory pressure, increasing the preload, so giving more fluids, or myocardial contractility to enhance cardiac output, or reducing the afterload to increase the cardiac output. Nutritional and metabolic needs are important to preserve organ function because protein calorie malnutrition is one of the primary signs of hypermetabolism in MODS. Because of the relatively short half-life, monitoring plasma transferrin and prealbumin levels will help assess hepatic protein synthesis. And again, the goal of nutritional support is to preserve organ function, so providing early and optimal nutrition decreases morbidity and mortality in patients with SIRS and MODS. The nurse notes that KR has developed petechiae and jaundiced skin. What do they indicate? Well, they indicate, jaundice indicates increased bilirubin, right? That's related to impaired liver function. And the petechiae could indicate DIC. What are some of the treatments you would anticipate being done for KR? Well, a priority is aggressive treatment of the infection, maintenance of oxygenation, so intubation and use of mechanical ventilation, and assessment of all body systems with support as needed. What are some of the treatments you would anticipate being done for KR? Well, a priority is aggressive treatment of the infection, maintenance of oxygenation, so intubation and use of mechanical ventilation, and assessment of all body systems with support as needed. Supporting failing organs is very important. ARDS requires aggressive oxygen therapy and mechanical ventilation. DIC requires appropriate blood products, and renal failure requires continuous renal replacement therapy or dialysis. Now, continuous renal replacement therapy is better tolerated than hemodialysis, especially in patients with hemodynamic instability. It's important to maintain communication between the healthcare team and the patient's caregiver regarding realistic goals and likely outcomes for the patients with MODS. It may be that withdrawal of life support is the best option for the patient. These are very difficult decisions and ones you'll be called on to help with. Let's do a couple of questions. A patient with a history of alcoholism is admitted to the ICU with hemorrhage from esophageal varices. Admission vital signs are BP 84/58, pulse 105, respirations 32. The nurse recognizes the onset of systemic inflammatory response syndrome upon finding what? Pulmonary edema, cardiac dysrhythmias, absent bowel sounds, or decreasing blood pressure. The answer is A. The respiratory system is often the first system to show signs of dysfunction in systemic inflammatory response syndrome. Increases in capillary permeability facilitate movement of fluids from the pulmonary vasculature into pulmonary interstitial spaces. The fluid then moves to the alveoli, causing alveolar edema and pulmonary edema. A patient is admitted to the hospital from a long-term care facility and appears to be in late stages of shock with SIRS. Which order implemented by the nurse has the highest priority? Insert an indwelling urinary catheter, insert 2 large bore intravenous catheters, administer normal saline at 100 an hour, or administer 100% oxygen by non-rebreather mask. Well, hopefully you chose 100% oxygen by non-rebreather. A patient is in irreversible stage of shock will demonstrate profound hypotension and hypoxemia. If the condition progresses to SIRS, the patient may experience profound hypoxemia. Oxygenation is a priority and should be initiated first with 100% oxygen delivery methods such as a non-rebreather mask. Okay, moving on.